So we're going to welcome Dr. Ivan Williams. He's the Chief Medical Radiation Scientist and Medical Radiation Branch Head within the Australian Radiation Protection and Nuclear Safety Agency.
Thank you. So today, I'm talking to you about emerging trends in radiotherapy. And first off, I'd like to just respectfully acknowledge the traditional owners and custodians of country throughout Australia and their continuing connections to land, waters, and community, and I'd like to pay our respects to them and their cultures, elders past, present, and emerging. And thank the UAE and FANA for arranging this workshop, this conference, and inviting me to present. So, this is what we're going to talk about, what just happened. Then we're going to talk about small fields, and then really small fields, and then fast delivery, and then really fast delivery, and just the concept of the rate of change of clinical practice over time is a whole lot faster than the rate of change of patient outcomes over time. Now, this isn't new, but it's just worth considering, and then look at a potential future. Okay, so that wasn't meant to happen. Let's see. No, okay, so what just happened? We've had a colossal increase in CPU, GPU, i.e. calculating capability over the last 10 years. 20 years, we're talking at massive increases in speed of data. So you can calculate things, Monte Carlo calculation of radiation dose. We've had the massive increase in the ability to hold data. So what it means is we have the computational capability to exploit technical advances on a LINAC, for example. Now what I mean by that is your modern LINAC now has dynamic capability in its collimator, in its gantry arc, in its pulse rate, or in its energy beam output rate. We can do modelling of tumour prediction. We can model normal tissue effects. We can look at tracking motion, uncertainty parameters, and the QA pretty much of every single item of equipment you've got, and as well as putting together really enormous research databases which can then be analysed using, again, fairly intensive computational techniques. We can do contour atlases, but all of this, it needs ethics and oversight to demonstrate that the product of these tools, which are often black box, are accurate, but also that we have patient consent to perform what we want to perform with that data. Because the commercialization capabilities of some of these are vast, and so I think there's an inherent requirement from an ethical perspective to understand what we're doing, how we're doing it, and the consequences of what we're doing, not just in the clinical sense, but in the wider social, environmental, and social license sense. So I just mentioned what happened in the technology space. We can now, in real time, using inverse planning systems, but due to the machine and motor control capability, we can change the rate of angle of the gantry rotation space. It can be stopped, halted, moved. Column rotation, likewise. Multi-leaf collimators are now dynamic. Current beam current dynamic control, all the onboard imaging capabilities. We can also do a real-time calculation of the day from data, from anatomical information which was taken while the patient is on the bed. This is really only possible because of advances not only in CPU, GPU, the ability to perform calculations, but also the way in which the calculations now performed are basically better than they have been previously. There are statistical reduction approaches and many others, all of which have enabled us to simply do more and better things. And it's also had an increase in the different modalities of treatment, again linked to technology, IT capabilities, and also mating or joining together imaging and therapy units such as the MRI LINAC and the PET LINAC. So these are now all in play right now. From a clinical radiobiology perspective, because the quality of data collection has improved, if we think about Emami's publication in 1991, it's the really first rather large delivery and discussion of wide population-based consequences of treatment, but also how to optimise fractionation. Then we have Quantec, more in the volumetric data, conventionally fractionated data, and NTCP modelling. It's free to download. It's a great guidance tool. In 2010, when it came out, it was the subject of conversation for many years. Most recently, we have HITECH, which is the next edition of this development, which is tissue and tumour impacts for hypofractionated radiation, but it also has standards of reporting. And this is also becoming more and more important, because if we don't know what just happened to the patient, we can't understand why what happened to the patient, collate it, report it, and put it together, and then learn from it. And then we have Pentech, which is the most recent, which is sort of high-tech equivalent, but in the paediatric space. And again, free to access, all online, all just a really amazing data set. And just to unpack some of what you get in the high-tech space, we have the pooled international data here, 26 normal tissues. So if we go from left to right, we go through Emami, Quantec, and HITECH. We can see we've got the NTCP in HITECH, all online, all useful, all good for clinical guidance. So if you're thinking about introducing a more modern equipment with more modern approaches in therapy, this is a great place to start to give you guidance and understanding of what is good as possible, really, large-scale pooled international data. We also have therapy integrated with immune and systemic therapies, so this is an ongoing thing as well. Makoto will be talking about radioimmunotherapy, so I'll just leave that there, but just understanding that radiation therapy is being developed and techniques to actually work with and enhanced by the human immune system. We have all the onboard imaging. We have MRI-guided radiotherapy, 4D, functional imaging, dose painting based on the functional imaging, radiogenomics, so we have biomarkers leading to optimized dose and personalized fractionation, there's potential as well as predictive biomarkers. This is not what hasn't happened. This has happened. This is in play right now. So I'm going to do a deep dive into one technology, and that's flash. So we talked earlier about super high dose races, super high dose rates, and very small beams. This point is where we're just talking about really high dose rates. So let's have a look at flash. Nominally, flash is at 40 gray per second or higher is a definition. But if you unpack what the beam structure or the pulse structure of a flash beam looks like, the instantaneous dose rate is far higher than 40 gray per second. So we have different approaches of flash, which we'll come to, which actually have different pulse structures, depending on the instrumentation, the machinery, the equipment which is used to deliver it. Now, all these approaches are termed flash. So how do we measure the dose rate? Calorimeters and ionizing chambers are usually what people would use in this space. Calorimeters are very precise, very accurate, very good. Because they work on change in heat, being a calorimeter, they're actually very good for high dose rate approaches. They're quite sensitive to that. They're actually very difficult to control. I look after one of them in a primary standards laboratory. The analysis of measurement is real. It takes a while. They're expensive and they're resource intensive. And it can often take about 2 to 3 days to get what you'd call a measurement using a calorimeter. Ionization chambers, we're used to them. Ease of use, familiarity. They've got good international protocols. But they've got protocols at a standard LINAC dose rate pulse structure. They require calibration. How do you calibrate an ionization chamber that's designed for 200 monounit per minute for 4,000 or 40,000 equivalent per minute? Specialized designs have been brought out, with some of them with quite high voltages or high potential differences across a narrow gap with specialized designs. And the other thing, what we don't know about flash is how it actually works. I think I'm happy to put that out there. Why does it work? Is it the same for everyone? If a flash beam stops in mid-treatment, what do you do? How does flash add up multiple treatments? Can you fractionate flash? Can we measure accurately the dose and the dose rate? And what is accurate enough to really predict and understand patient outcomes? And we're not necessarily talking about a week or a month. We've just been hearing about second primary cancers decades after the event. If delivery is interrupted, can it be recommenced? So this is the perspective of Paige Taylor. Now she works with IROC, Imaging Radiation Oncology Core in Houston, and this is an example of the sort of work and understanding that we should have for really any new technology, but specific into the flash space, of the sort of things we need to have an understanding of to understand flash. So, have technical advances improved patients' outcome? Indisputably, yes. There is no doubt that complications from radiotherapy and advanced doses and all the rest of it have improved. Here's some examples. And I think we really need to recognise that as a take-home method. Not only does radiotherapy work, it is getting better with the application of technology into the space. Over the last few decades, we've seen enormous increases in technology which have been applied into every aspect of treatment and all the contributing pathways that result in the treatment of a patient in radiotherapy, which have improved outcomes. And we also need to understand that our full understanding of the consequences and how all these processes work is probably beyond our understanding at the point of introduction of the technology. But for us as users and also thinking about patient safety, it's incumbent on us to develop as greater understanding as fast as possible so we can really understand what is happening and that a given treatment path is justified. And it's also worth noting that given the data structures that we can now work with, there are opportunities to hold, save, record data, contribute to pooled international data sets, which will give a greater understanding of how these new technologies work faster than ever before. Thank you.
Thank you very much, Ivan, again.